ओके, ये इसको यही रखें, ना घुमाना भी ना घुमाना। चलिए, गुड। क्लोज करें, नहीं ओपन, अब क्लोज करें, फायर। थैंक यू।
Khalid, sorry, Farooq.
जी,
Generally speaking, you would put on average about 5 to 6 clips,
ऐसे
right?
बिल्कुल ऐसे, बिल्कुल।
And do you have any preference when it comes to using the clips for
Yes,
this?
true. So my first one is always 16.
Okay, so you use the 16.
First one.
Okay.
And then you can, once the zip line is established,
Yeah.
then even 11 is okay.
Okay.
For the rest of it.
So you use the first one is 16 and then you're okay with 11. as
11. Once, because वो हम zip line बनाते हैं इसीलिए कि वो दोनों folds उठ जाएं.
well? Okay.
So then it becomes easier for us to clip it on.
Okay. And once you've done this post poem, I heard you speak this morning. So post poem, this patient is going to be having a gastrographic swallow tomorrow.
ऐसा ही है, बिल्कुल ऐसे. So
Right.
one night we do.
And then they remain on liquid diet
For 48 hours at least. I
Yeah.
prefer that.
for 48 hours, and then they can start soft and then
Soft.
gradually, you know.
So
they
2
go
days
on.
liquid, 3 days soft, and then normal.
Okay, they will have some surgical emphysema in some cases, and
Yes,
so
yes.
they need to be told beforehand.
Yes,
They will have
yes.
some pain. Again, you can tell them
Oh,
not
they do.
everybody.
पानी दे दो. Thank you. जी बिल्कुल, बिल्कुल, बिल्कुल. ये fully open है?
Yes, sir.
नहीं, वो एक किसे घुमा देता है. चलो, this is fully open.
Farooq, you're going to use fluconazole in this patient?
So we should have. I don't think.
Okay,
that
yeah,
there's
all
much
right.
Evidence. now.
We will. You're the captain. What's the rationale for using fluconazole? I heard you say this morning, but I couldn't hear it clearly.
So I think they get inflammation of the mucosa. Close, close.
Yes, close it, sir.
Fire,
row.
fire, fire.
Yes.
Thank you. Sadhvik, so what happens is their chance of mucosal integrity increases when you treat inflammation. That's why we put them on Nexium, number 1. Number 2, we know from the evidence that fungal infection is not uncommon and that impairs that inflammation. So it's a Spanish group, Eduardo does it, and he is the one who's forcing me to do it as well. But I do it, I must admit. So now it's closed as you can see, but I will still put one more clip.
Size
11,
11.
16, I don't know, 16 कोई नहीं. Yeah, so far we put 4 clips, है ना? कि 5.
Yes. Up number 5.
So now we're getting the 5th clip.
Can we go to Khalid Saab's room? It should be.
Like.
Hello, Khalid Saab.
कहाँ पे लाइव आ गया नहीं हमारे पास तो नहीं हमारे पास तो लाइव
What is starting right now is basically a 54-year-old female with history of recurrent coughing while eating. Her past history was that she had GBS and prolonged intubation, after which she developed tracheoesophageal fistula, which was at 17 centimeters from the incisors. So this is now an attempt to close it.
ठीक है रेडी हैं आप Yes, sir.
Khalid, we are with you.
Ji, Saad bhai, I just briefly looked at that and I'm just a little bit concerned about this fistula. It's not a small fistula, it's almost 2 centimeter. It's really close to the upper esophageal sphincter. I think you have done endoscopy on her. ठीक है सब? ठीक है? आप लोग ठीक है? Okay, light on करें.
Patient symptoms have over a period of time somewhat settled where she's able to eat solids. But
Yeah,
she continues to have symptoms.
I
When we
don't
looked
know.
at it,
Arya, let me show it to you. I don't know how she's eating solids.
yeah, that's what we couldn't
And
understand. But then we said we'll bring it
yeah, so
for
let me
people
show it
like
to you.
the masters.
This one is gonna be, it's right, that's the upper esophageal sphincter. You see that?
We can
ठीक
see
हो आप
that.
लोग या मैं निकाल लूँ okay ठीक so you see that's a fistula right there, okay, and the fistula I think would have a better chance with the, if we see it with the cap ठीक हो या
तो
बता
कैप
देना
लगा
मुझे।
लें.
हाँ कैप मैं लगा लेता हूँ लेकिन कैप की ज़रूरत भी नहीं है you see that how big that is, that's a fistula by the way. That's a humongous fistula, and it's all epithelialized, and right below the upper side. You see that trachea there? Look at that. That's all, by the way, fistula. It starts right here and goes downwards. It's a very big esophagus is on this side. That's the esophagus. बेटा मुझे बता देना अगर बंद करना है तो ठीक है और this is a look at that fistula. That's not really a fistula, that's a gap. There is a complete and it starts right up here, right below GE junction, not GE junction, upper esophageal sphincter. That's where it starts. It keeps going down, keeps going down. Look at, that's a trachea. So the couple of things here. If it was a small, I can use over the, I will pull this out, आप लोग इसको settle कर लें, and we can talk, because I don't, so the thing is, इसका ये है कि this is at least 2 centimeter long, और Vasco और padlock उधर आ जाते हैं, उस तरफ कर लो, वो उनको settle कर लें, ठीक है. So, a Vasco and padlock, these are over the scope clip. They can usually, if it's an acute perforation, 1 centimeter, 1.5, even up to 2 centimeter, we can take care of that. So usually it's not easy to close. Issue right here is, it's almost 2 centimeter long. It's completely epithelialized. On top of that, if you try to put a Ovasco or over the scope clip, you will grab the opposite wall of the trachea. You run at risk of closing the trachea as well. That's one. This is not a space, there is no space to do a suturing here. If it was in the, you can't even put the endo stitch there, that over stitch scope there. So that's another problem. Stent, you can't put it because it's so high up there. She's not gonna tolerate stent. And these are the patients either need surgery, and if we do any endoscopic therapy, we need to put a tracheal stent first because we got to make sure that we protect the trachea. So this is unfortunate. I think we need a help from the our colleagues. Maybe Dr. Sajda can comment on that as well. But this one, before doing anything, is going to need a tracheal stent first. So I don't think it's any good idea to do a clip or stent. Stent she's not going to tolerate. Stitch you can't do. Ovasco, yeah, or padlock over the scope clip you can do. But the problem with that is going to be that it can grab the other side of the trachea. So that's where we are, Saad Bhai. If it was anywhere downwards, little bit down, and then in that case, yeah, you can try to contemplate if endosuturing would work, but still should not be done without tracheal stent. You are run into a risk of grabbing the other side of the trachea.
Khalid, there are two questions. One, what about if she's intubated and done?
So that is one thing, but this is not gonna close. That's the issue.
No. This was related to protecting the.
Yeah, we can, but that tube, endotracheal tube, if you use a over the scope clip, there's a risk of grabbing that too, with that
And if it grabs it, it's a big
because it's a plastic.
clip is a real
Yeah,
problem.
that's a real issue with that.
We have, fortunately, we have a surgeon here as well, so we'll, and her interest is upper GI.
Personally, I agree with what Dr. Khalid is saying. I think this patient is a candidate for surgery, not for any, endoscopic thing. But if you're going for endoscopy, because personally I feel the opening that Dr. Khalid had just shown is far too big to be covered just by the vasco, number one. Number two, the opening into the trachea is quite big as well. So that needs to be closed for a long term, with her underlying conditions. So I think she's a candidate for surgery in which she needs both tracheal as well as esophageal repair, not just that, but an interposition of a tissue in between so that that does not reform.
Yeah, and other thing, like not this case, if somehow if it was a fistula in the stomach, distal esophagus, it's epithelialized. So we know that two epithelial linings, it's so hard to close. They don't close. You can put clips on the stomach and try to clear our esophagus, try to close the lumen. Epithelial lining is not going to attach to each other. It doesn't close. So in those cases where you think you are going to provide you are able to provide the endoscopic therapy, you need to burn the epithelium into the fistula. Can you hear me?
That needs to be denuded, yes.
Okay. So use a APC to burn that area. Okay. Thank you, Saad bhai. Thank you.
Thank you. So you have multiple options for closing a fistula, and obviously that's what we discussed. You can, if it's very small, you can use the clips. If that doesn't work, you have ovescos or other keys, and if that doesn't work, you can put a stent sometimes. But the problem is in a normal duct, a normal esophagus stent doesn't stay; it migrates very quickly. So you need to stabilize it. Endo stitch is something that you can use to stitch, but then you need to have enough space to get in. So those are the options you have. Mustafa, we are with you.
So this was quite the adventure. We tried 2 cystotomes that didn't work. We tried a needle knife, that didn't work. Eventually we ended up putting a hurricane over the wire, and that, with I guess some trauma from the cystotome, allowed us to go through. Then we balloon dilated to 4, used a 10 French pusher to go over the first wire because I wanted to secure it with 2 wires.
Mustafa, just one question. You dilated it to 4, did you say? Did I hear you right?
Yeah, because I used the 4, I was initially planning on dilating it to 8 to 10.
Okay.
But when I used the 4 hurricane, I had enough of a track to put in a 10 French introducer. And we put the introducer up to it, the introducer wouldn't go. So we then put in a second wire alongside it and just followed the track. And now we've used 7x4 double pigtails.
So you got 2 double pigtails there?
Yeah.
And I can see some infected stuff coming out.
Yeah, she got antibiotics for the procedure. Obviously, we'll keep her on. And it's all liquid mostly, so I think it'll drain out. It's just a matter of time.
Can we see the fluoroscopic picture, please?
Yeah, it's also a head-on for fluoro. Can you see it?
Fluoro दिखा दें एक दफा, please.
You see it?
Yeah, we can see that, yes.
So I think we're going to stop here. It's draining nicely. I think it's just giving it time.
Yep.
So ideally, I would have dilated it more, but I didn't want to add more steps. Also, intermittently, I was turning off the CO2. One of the issues when you start cauterizing and you don't go through is that you end up in no man's land and you can get CO2 or air leakage outside the gastric wall. So I would turn it off and turn it back on, but thankfully, alhamdulillah, that worked out.
Okay, thank you very much.
Thank you.
So, I think we have time for one more case, if possible, before we go for lunch.
I don't know what happened. मुझे पता नहीं चला कि हुआ क्या, लेकिन वो सोप वाला इंटरेस्टिंग था.
what
तो
is
क्या
your preference?
पैड पे
पैड पे सोप रखा सर मैंने
अच्छा
और उसको सोप को
और गीला क्या किया शुरू में गॉस क्या था
बहुत से गीले बैठ किया ना मैंने
पैड को
पैड
अच्छा अच्छा
उसको बाहर चेक करने का आसान तरीका बाहर
और soap acts like the human body कि उसमें current conduct I did not
Any cyst that's more than 10 centimeters on CT, I would put a duodenoscope first. If I see a very nice bulge, I would do an endoscopic drainage and forget about EUS. My EUS is ready. If I don't see a bulge, I don't see nice flattening of the stomach, then I wouldn't watch it. यार आप कोई मुश्किल काम कर नहीं रहे, ये तो आसान वाले तो फिर हम आपके लिए तो नहीं रखते थे, तो खुद ही कर लेते हैं.
सही बात है, ये तो आप भी कर सकते हैं.
नहीं ये वाला तो
बैठे बैठे स्मोक के
इसका तो बहुत अच्छा है. So I was telling them our practice, and I've shared this on international forum, and nobody. So we see a bulge, we go in, and that's based on 10 centimeters. 10 centimeters is our cutoff. If the cyst is less than 10 centimeters, then we don't usually. We still would do that, but on CT scan you can see the stomach being compressed. If that's the case, I would do an endoscopic drainage. We did it for years, and everybody said fantastic, and then came US and everybody said that's not good.
But how are you going to rule out superaneurysm?
Okay, CT scan would help you.
But not always.
Well, even otherwise, what will happen is, I mean, I have not seen any. Okay, but I'm not sure I would be able to do that on, on even, if you look at, there's one trial that was done, and I looked at literature. There's one trial that I actually looked at it, this is years ago, looking at the complications of endoscopic versus EUS guided. The problem with that is that at that time we were becoming a little bit more, what would be the word I'm missing? But anyway, and so with bulges that were not very nice bulge, people would put in a needle because the EUS option wasn't there, and so hence you would run into trouble. I think the most important thing is that you should see a smooth gastric wall. If you're seeing rugates and you're seeing a bulge, I think it's not here.
I agree. I totally agree.
And why do we do that? 50% of our cysts are drained endoscopically, which saves us EUS needle. Just EUS needle is such a heavy cost on us. Forget about the cystosome and everything. So that's now we will. We got I think 114 cases or something like that, divided into two, and they're writing it out. So in that case, what we do is we see a bulge, we put a needle knife. We take a needle knife, we go straight in. And once you done the needle knife, you just put a wire in. And what I do is I want to see fluid coming out. And usually you'll see a nice gush of white fluid or whatever coming out.
I said, do you use chloro?
Yes, we use chloro. We use chloro for that, and obviously, initially, general inject करते थे लोग उसमें, but obviously that was very early on when I did my first endoscopic drainage of pseudocyst, endoscopic drainage in 1998. So this technique has been going on, and then EUS came. At that time, EUS was not there, therapeutic ES was not there. Now therapeutic ES has come, but the cost of is significant, and so we save about 50.
Have you tried with US going directly to the cystosome rather than a needle? Or the axial assembly? See what I mean? So I was just wondering, that would be a good midway. You have excluded
The other thing that where I feel is that EUS guided plastic stent placements are cumbersome, no question about it. Whereas endoscopic drainage is very, very simple. Takes you 10 minutes. And you put 2 10 French stents. But it's debatable, obviously. Nobody's going to accept it. The developed world has gone way ahead. They will not accept it. They're not, very soon, guidelines probably will not even have hystoacral injection as treatment for gastric varices. Another 5 years, and you will be told how wrong you were when you were doing that. But that's not based on, I challenge some of the authorities. It's not based on quality, that's based on cost.
So what about reusing USA, that is fiscalize it properly and reuse it? What are your thoughts on it?
उस पर हमने काम किया है थोड़ा. Obviously यार कोई दुनिया में बोल नहीं सकता. Indians are reusing, ठीक है? उस पर इतराज नहीं है. लेकिन अगर आप कोई चीज़ ऐसी करें जो एडवांसमेंट से आप वापस थोड़े से पीछे आ रहे हैं तो एवरीबडी से सारी दुनिया नहीं, majority दुनिया is reusing. How many times can you reuse? That's the question. We use needle में हम जब biopsy specimen लेते हैं तो I use suction obviously. Number one. Number two, obviously you have to be careful. There's a lot of hepatitis C, there's a lot of TB here. So you need to be very careful कि आप किस पेशेंट में तो lymph node वाले के जैसे कल आप केस किया था उस किस्म की केस के नीडल को हम दोबारा यूज नहीं करेंगे. फिर उसमें ये करेंगे कि we will change the needle. We are now working on using the assembly, putting a new needle. Okay, so there are other options. Internationally, या आप सबके सामने अगर ये चीज़ें बोले तो obviously Boston will be very unhappy and everybody will come on मुझे क्या कर देंगे. But we have to find ways of making it, आप हम अगर खालिद जो है ये लोग करते हैं, खालिद 3,000 plus US,
4,000, close to 4,000
US. आप कॉस्ट निकाले 4,000, you will see 5 to 4,000. So we have to
different
dynamics हमारे different and we have to see, one of the things I've learned, and rightly or wrongly I don't know, but guidelines are made for the West. Sorry, let me complete my statement. Guidelines are made for the West with the availability of the equipment they have. They cannot be applied to the rest of the world. Okay, things may have improved, but not for the rest of the world. Doesn't mean that we need to, I mean, like for example, we went to this workshop and now studies. How should you be treating gastric varices? Wait for another few years. Guidelines will tell you the way forward is US guidelines. How long have we been using histoacral injections? Much before the rest of the world, right? And what was the result? How many complications? I've never had a single death because of glue going elsewhere because you're not injecting that much. Yeah, everything has its right. But आपने guidelines तो बना दी, आधी दुनिया के पास US ही नहीं है, तो क्या करेगी? So guidelines don't take into account what you have. You need to look at what you have and take what you think is applicable to you. That's what I mean. The guidelines are not made for, they're not based on, I'm sorry, labs कैसे हो सकता है? आप मुझे एविडेंस देंगे अगर स्यूडोसिस ड्रेनेज में लैब्स की कैसे देंगे? चले आप नहीं बॉन्ड में दे देंगे, लेकिन स्यूडोसिस में क्या एविडेंस देंगे? लेकिन फिर भी रेकमेंडेड हो गई. देखिए फारूक कॉस्ट का बड़ा we have to be upfront. Yeah, there's $250 million की सेल थी last year of labs alone. $250 million. 2 million इन्होंने यूज
Literally, 2 million हमारे डॉलर के लैब्स हमारी के
UK में इसका major problem क्या है? It's not about using the labs. It's about using it. Because this week the other one when जिनके पास e-response क्या है? People will just take it in because it's just so easy. the access of lamps into different parts of the body has become so easy that people are actually doing it that even it's not indicated. So patients are coming through now because it's easy. 53 seconds. We have time rate from sticking the scope and draining it out. 53 seconds.
If you put
200 pounds.
फारूक मैंने अभी एक चीज है नहीं खालिद ने मैंने खालिद से भी डिस्कस किया ओके
and then we will do 4 cases after.
ठीक है तो we have a lunch break
After that,
वो मैंने फोन कर लिया आपने लेकिन उसमें